Hi, my name is Carrie Griffin, and I'm a nurse practitioner student at Auburn University. Today I'm going to be talking about contact dermatitis. Contact dermatitis is a delayed type of hypersensitivity or inflammatory response of the skin caused by an allergic reaction or contact with an irritant that causes a skin reaction. The two most common forms of dermatitis are allergic contact dermatitis and irritant contact dermatitis. Irritant contact dermatitis is the most common form. It can quickly develop when a substance or irritant comes in contact with the skin, causing a rash. Common irritants are metals, rubber additives, preservatives, or additives in skin products like creams, lotions, sunscreens, cosmetics, fragrances, dyes, formaldehyde that is often found in shampoos, topical medications, and occupational exposures to irritants are very significant. Allergic contact dermatitis is the second most common cause. When a patient becomes first comes in contact with a new allergen, the body's immune system analyzes and stores the allergen during a process known as sensitization. Contact with the allergen thereafter can cause an itchy skin response. Sometimes allergic contact dermatitis can be delayed due to the body's process and the body's immune system to recognize the allergy. The skin can take 48 to 96 hours to develop a reaction. ACD may be limited to the site, but it more often spreads and the skin becomes red, hot, itchy, and may weep. Prototypes are poison ivy, poison oak, and sumac. Symptoms of contact dermatitis are red, irritated skin, extreme itching, swelling, bumps or blisters, hot or tender skin. Symptoms may range from mild to severe and may appear anywhere from a few hours to 10 days after coming in contact with the irritant or allergen. Risk factors for developing: people with a history of a medical history or a family history of eczema, allergies, hay fever, asthma. People that travel, occupational hazards such as jobs or hobbies that put people in contact with certain metals, solvents, or cleaning supplies. Some of these occupations would be like nurses or healthcare providers, hairdressers, chefs, auto mechanics, gardeners, or florists that come in contact with plants, farmers, housekeepers that are in contact with household cleaners frequently. 3 questions that are essential to ask a patient during a workup. They really need to describe their past medical history, including allergies to food, irritants, or drugs, and a family medical history, and as well as a social history. All of these are very important that help the provider narrow down triggering substances versus an allergic reaction. Some forms of dermatitis, such as atopic dermatitis, which is eczema, have been found to have genetic links. So understanding the patient's history is very important. Also, you need to have them describe the signs and symptoms of the rash. Is it isolated to one area? Does it spread? How often does it occur? Is it constant? If so, how long has it been occurring? Are they aware of any triggering substances like new lotions, detergents, soaps, perfumes? Any of that can help the provider also narrow down and differentiate between allergic contact dermatitis and irritant contact dermatitis. And lastly, the occupation is very important because occupational history is a form of usually an irritant contact dermatitis, and irritant contact dermatitis is the most common form of contact dermatitis. What are the most important physical exam components? We want to examine the rash itself, examine the shape, pattern, and the distribution of lesions. Allergic contact dermatitis is characterized by pruritic papules and vesicles on the skin, and they usually are well demacerated eczematous dermatitis. So the hands and the face are the most common localized area. Pruritus is the main the main symptom you see with allergic contact dermatitis. For instance, the hallmark sign of poison ivy, you're going to see a linear dramatic lesions. With occupational dermatitis is often caused by irritants. So the workers may develop a rash on their hands or whatever they're touching, and then you may see those symptoms actually improve when they're off of work and not coming in contact with those irritants. So the initial site of the dermatitis often provides the best clue regarding the potential cause of the rash due to the process typically being confined to that site of cutaneous exposure. Reviewing the clinical symptoms associated with the rash. So you want to review and ask, is the rash burning? Is it itching, stinging, soreness? Are they having pain? with the irritant, you're going to see all those. With the cardinal sign of allergic contact dermatitis is the pruritus, or the itching. The contact dermatitis is not contagious, so if you ask, is anybody else in the family or anyone living with you have a rash that's similar to yours, that'll help the provider kind of narrow down and determine whether this is contact dermatitis or something else. The patient's recall of events is very important to determine the clinical characteristics and initial affected sites. The rapidity of onset after exposure and the description of the clinical course can help the provider distinguish between the two different types of contact dermatitis, which is irritant and allergic. Patch testing is the gold standard for diagnosis of allergic contact dermatitis. Most commonly, you're going to see in the dermatology clinics, you're going to see 80% of that's irritant contact dermatitis, but 20% are allergic contact dermatitis. It is very difficult to distinguish between the two, so that's why history and the patient providing a good history is very important. But if the rash continues after treatment, a patch test may be necessary to determine, and the patch test is the gold standard for diagnosis. Here are just some treatment options for contact dermatitis. So you want to identify and avoid all allergens or irritants that may be causing the rash. Work modifications may be necessary for the occupational irritants. So providing protective clothing and eyewear may be necessary. You want to simplify the skin regimen. So discontinue all moisturizers, lotions, topical medications like bacitracin. You only want to use plain petroleum or like Vaseline or emollients such as AUBURN. Bathe with mild soaps and lukewarm water. For more severe or generalized dermatitis, they may need a topical steroid cream or a 3-week tapering course of oral steroids. And then if the rash continues, they may need to be referred to dermatology for a patch test. Here's some medications. First line topical medications would be like Gold Bond ointment or cream, the Eucerin. Calamine lotion will help with the symptomatic relief of itching. Oral histamines will also help with itching. Topical corticosteroids, would be high potency, would be Lidex, which will be a more severe rash. You also want to make sure you use a lower potency for any facial or skin fold rashes and avoid prolonged use of these topical steroids. Same thing with the oral steroids. You want to avoid prolonged use, but if the topical steroids are not working, you might want to use a tapered dose of prednisone for 10 to 14 days, 21 days if it's more severe. And then if they develop a secondary skin infection, you want to treat with oral antibiotics, augmentin, if they're allergic to penicillin, erythromycin, doxycycline, or bacitracin. Bactrim if you're considering this to be a staph resistant type infection. The main takeaway is to remember contact dermatitis is caused by an allergen or irritant, so determining that allergen or irritant and avoiding contact with it will help with alleviation of symptoms. Also provide thorough clinical history, including past medical history, family history, and social history. That's hobbies, travel, occupation, to determine that, to help the provider determine diagnosis. And contact dermatitis is not contagious.